the next speaker, Dr. Raghav Preetam. He's talking about alcohol woes, a tale of recurring and habit and corneal edema, habitual corneal edema, I guess.
Everyone. At the outset, I would like to thank AIOS for the opportunity. Today's my topic is alcohol woes, a tale of recurring habit and corneal edema. Directly jumping into the case is a 33-year-old gentleman who is a bike mechanic hailing from Don, Kurnool district, complains of sudden onset of pain, redness and decrease in vision in the right eye. He's giving not so consistent history of trauma to the right eye and no other systemic associated history. He's a social drinker and is a non-smoker. So on clinical presentation, in the right eye, vision was counting fingers 2 meters and the IOP was 24 millimeters of mercury. We did it with NCT not GAT because of the following findings. So on diffuse direct illumination, a total corneal edema, limbus to limbus could be seen. The same could be seen using a slit section where you can see gross increase in the corneal pachymetry and no KPs or pigments were noted on the endothelium. The same picture using a sclerotic scatter and on fluorescent staining a 4 into 4 mm epithelial defect could be noted. So almost always I always have a presumptive diagnosis seeing the first eye. Sudden onset of edema, corneal stromal edema. I was thinking in lines of HSV before I just checked the other eye. Grossly it looked fine, but on looking it further closer you can see some DM folds on the slit section. So then there was no fluorescent stain was negative, no epithelial defect. So then the confusion started. Then I went back to the book and started seeing what are the possible causes. First clinical diagnosis, differential diagnosis was viral endothylitis secondary to HSV or CMV. Whether any toxins were used or whether the patient had any endothelial disorders like FECD, PMCD, none of which had consistent features. The trauma history was there, but I was not convinced with the amount of trauma and the extent of trauma in both the eyes. And the last differential was drug induced, whether the patient was any of one among these medications. So I went back, I asked him, probed more questions to the history. So there was no significant medical history or he was not on any drugs. Events from the previous night suggested an episode of binge alcohol drinking, following which he developed the symptoms the next day morning. He also rubbed his eyes vigorously, possible reason for why he had an epithelial defect. So I placed a BCL in the right eye, started him with hourly steroids in the right eye and 4 hourly steroids in the left eye. Atropine in the right eye for 3 times for the pain and paracetamol as well for the pain. Started him on Biplex Fort OD, thinking that he might have some kind of a vitamin deficiency as well, and was advised for complete abstinence from alcohol. A basic serology workup was done which was within normal limits. So this was 1 week later. In the right eye, vision improved to 636, BCL was removed, IOP was within normal limits. Left eye came back to 66 and the IOP was normal. Further 2 weeks later, there was faint antiostromal scarring and the vision improved to 612 in the right eye and IOP was normal as well, 18 mm of mercury. So at this point of time, I was very happy. I showed the patient the pictures, how it was, how it is right now, why it is important not to drink. And 3 days later, boom, he comes with another episode of drinking and the vision is back to 660 in the right eye and 636 in the left eye. So again, I stepped up the steroids, started him on acetazolamide because the pressures were borderline high. I advised him to go to a DA addiction and rehab center. That is the last I saw him. He never came back to me again. So to quickly about the discussion, temporary dysfunction of corneal endothelium with loss of endothelial cells is possible in binge alcohol drinking. This could be possibly due to prolonged hypoglycemia as well. Considering the temporal sequence, prominent resolution is expected, but complete visual recovery might not happen. That is all what I had, and these are my references, and thank you.
Thank you for your wonderful case. I think one case probably is too small a number to make the cause and effect. Bilateral viral endothelitis is also known to present like this sometimes, especially with you tapering the steroids and the recurrence coming back can also be attributed to that. Maybe the others on the expert panel can comment.
I have seen one case of bilateral corneal melt after this alcohol binge drinking. We have done bilateral therapeutic PK. It happens, but we can't make it like it is the cause of this. We have seen.
No, good, I would say very good documentation, except that the first picture, the initial picture which was of a very diffuse edema on one eye and the other eye being almost normal, that is inconsistent with alcohol-induced toxic endothelitis. So we have a publication which is just accepted in the IGO, and probably in the couple of months it will be coming up. And it would mostly confer with your picture that you showed in the second visit. The first visit is a bit too inconsistent. This is point number one. Point number two is sometimes alcoholism we may need to gravitate towards thinking that alcohol might cause this, but they may have secondary infections, and we had a very similar case like your first presentation, and when we scraped, after 5 scrapings we got atypical mycobacteria over there. So while this is plausible, what I'm saying is that this is, as in your very rightly pointed out differential, it's one of the rarest
Correct.
prognosis that is, differentials that is there. So in that light, I think otherwise, I think it's a wonderful case to document and discussion.